Hello, everyone. Thank you so much for joining us today. I am Christine Millen, class of '05. Thank you for carving out time from your busy schedules to be with us. I am here with Dr. Kimberly Harris to do a Q&A session. And we plan to cover questions today surrounding the mind-gut connection, the immune system, and gut health, along with diet. Thank you to those who submitted questions prior to our session today during registration. We were able to incorporate quite a few of those into our conversation. I will say some of them were a little bit specific, so we were not able to include them today. And to that end, you can also submit questions today while we speak, and we will do our best to answer them at the end of today's session. And anything, again, too specific, we may not be able to address. And okay, so without further ado, let me introduce you all to Dr. Harris by sharing some of her background. Dr. Harris is board certified in internal medicine and gastroenterology. She completed her undergrad at Miami University, and she earned her medical degree from The Ohio State University College of Medicine. She completed her combined internal medicine and pediatrics residency at the University of Pittsburgh Medical Center and her clinical fellowship training in gastroenterology at Vanderbilt University Medical Center. Dr. Harris currently practices at North Shore Gastroenterology, which is located in Westlake, Ohio. She is board certified by the American Board of Internal Medicine and the American Board of Pediatrics. Dr. Harris has contributed to various publications and presentations focused on gastroenterology, hepatology, and pediatrics. Her areas of special interest include irritable bowel syndrome, inflammatory bowel disease, colorectal cancer screening and detection, and the management of hepatitis C and chronic liver disease. One quick thing before we get into our questions today, I just wanted to mention that today is a conversation for general purposes only. So if anyone has some very specific issues or problems, please do consult your own medical practitioner. So thank you, Dr. Harris, for joining us today.
Hi, thank you for having me.
All right, so let's jump into the questions that we've got. So the first section that we carved out was to talk a little bit about the mind-gut connection. So for a baseline for this part of the conversation, Dr. Harris, can you just tell us what body parts encompass the gut?
Yeah, so generally speaking, the gut is everything, all the organs that would be responsible for helping digest food. And so you hear the term GI tract, and that's true. It is an interconnected tract of organs starting after you swallow. So from the esophagus down to the stomach, the small intestines, and then the large intestines or the colon. It also includes several other organs that people might not initially think of. The organs that would secrete and store enzymes that are responsible for aiding digestion. And that includes the liver, the gallbladder, and the pancreas.
Got it. So can you tell us a little bit about what exactly is the connection between the mind and the gut?
Yeah, so the GI tract is actually thought of having its own complete nervous system. It's called the enteric nervous system. It's a very complicated meshwork of about 500 million neurons, which is about 5 times what you'd even find in the human spinal cord. For that reason, sometimes it's referred to as the second brain, and it can function completely independently of the human brain. But there's also a really complex interplay between the brain and the enteric nervous system. They actually both use the same signaling molecules called neurotransmitters to communicate. In the gut, these neurotransmitters are responsible for controlling muscular contractions and also the secretion of different hormones that aid in the digestion of food.
Okay. So mental issues can cause problems with the gut, right? And then also I guess the flip side of that is can an unhealthy gut cause mental issues too?
Yeah, very much. So it's really a back and forth communication between the gut and the brain. Okay. A lot of people hear the term nervous stomach, and it is a very real thing. When the body is under acute stress for whatever reason, say they're giving a lunch talk, the sympathetic nervous system starts kind of revving up and generating all those neurotransmitters that I mentioned. And they're really designed to help facilitate the fight or flight response, as we talk about. You encounter a danger out there. Are you going to, fight it off or run away? But the enteric nervous system also responds to those neurotransmitters that are circulating, and you might start to develop symptoms. So someone's about to give a big speech and they suddenly have nausea and cramping. They might have vomiting, diarrhea. But conversely, when you're dealing with a true organic GI disease, you might start to develop some issues with anxiety, depression related to the symptoms that you're experiencing. So there is really a back and forth play between the enteric nervous system and our parasympathetic and sympathetic nervous systems.
Got it. So you kind of touched on this just now, but what are specific symptoms someone might experience if they are having an issue with that mind-gut connection?
Yeah, I think you'll hear this throughout the talk today, in that the GI system has a lot of kind of vague symptoms that overlap between multiple different diseases and different processes. And so really a patient might experience any number of things. They could have abdominal cramping, nausea and vomiting are very common, bloating symptoms, constipation or diarrhea. It really can be anything across the board.
Okay, got it. What are some ways people can help improve that relationship between their gut and their mind?
Yeah, a lot of patients come to me with, initially they're coming for symptoms of abdominal pain, vomiting, diarrhea. And in the course of our conversation, we start to uncover a lot of underlying stressors for them. They might be going through a divorce or, taking a challenging course in college. And their symptoms are starting to become more pronounced and maybe interfere with their day-to-day life. What I talk to my patients about is that our stressors in life do not just go away. Mm-hmm. What is a stress right now might fade and a new stress kind of replaces it. And so what's really important is for my patients to work on practices that help us cope with stress. And for some patients, that's simple as relaxation techniques, which is different from person to person. What might be relaxing for you is not necessarily the same for me. And so for some patients, that might be an exercise program, yoga, meditation, journaling, reading, art, massage, really anything that helps them kind of relax. Other patients might benefit more from really focused psychotherapies with a trained specialist. And these are things like cognitive behavioral feedback and biofeedback, where you generate a greater awareness of the processes that are happening within your body and kind of gain the ability to manipulate those processes at your own free will. Finally, I prescribe probably the number one medication class of medications that I prescribe is actually the class of antidepressants. I always, when I'm talking to patients about this, kind of bring up that I really hate the name that class of medications was given, because these medications do so much more than treat depression. And the medicines that I commonly use are actually very infrequently prescribed for true depression. I often tell my patients, think of these more as, medications designed to alter those neurotransmitters that I talked about. When someone's depressed, your doctor might prescribe it to help alter the neurotransmitters in your brain, mm-hmm. to impart change on the depression symptoms. For me, I'm prescribing these medications to alter the neurotransmitters in the gut and thereby help your gut symptoms. So about 90% of the serotonin, one of these neurotransmitters that's found in our body, is actually located within our gut. And so I commonly prescribe a medication that alters the serotonin transporters in your gut to help with the symptoms.
Interesting. So do you typically, maybe ask patients to try to figure out their own methods of relaxation to see if that would work, or maybe, talk with a therapist or some other professional to try and work through some other things that you mentioned before trying the medication? Or is it just really up to the patient's individual situation?
Yeah, it can be a little bit independent. Sometimes patients come to me, they already have a psychiatrist that they're working with. They might already be on medications for true depression. Mm-hmm. And I, either add a medication to that or kind of tweak their medication dosing to get more gut specific treatment out of it. Okay. If they're already doing that and we don't want to make changes, or they're stable on that, then focusing more on the biofeedback or cognitive behavioral therapy. And I think in general, all of us could use a little bit more relaxation these days. And so paying attention to kind of our own coping mechanisms for stress.
Well, that's super interesting. I never really thought about, utilizing those types of medications to affect your gut transmitters too. Very helpful. So are there specific foods as well that people can maybe look to help with this connection? And then conversely, specific foods to maybe avoid if they're having issues and problems?
Yeah. So in general, it's the diet is very complex when it comes to GI issues, but in the general sense, eating a healthy diet that would support your gut microbiome, which we're going to talk about in a little bit. So you really want to focus on a diet rich in fruits and vegetables, especially the root vegetables, which actually contain natural prebiotics. Again, something we're going to talk about. And diet rich in omega-3 fats, which are important. So you can find those in nuts and berries. And then avoiding, of course, excessive red meat intake, which not only is bad for the gut, but can increase your risk of developing cancers, both within the GI tract and throughout the rest of the body. Avoiding excessive sugar intake and avoiding overly processed foods, all of which can lead to that more unhealthy gut microbiome.
Got it. And when, if someone's having some of these issues that we're talking about, like when would you encourage someone to maybe seek out help?
Yeah, I would reach out early. I think a lot of people, by the time they come to me, have kind of exhausted everything on their own. And they're very frustrated by the time that they come to see me because everything that they've tried and read about has not worked. And so I think reaching out early, if you start to feel like you may have an issue with the mind-gut connection, to help, get those resources activated early on so that we can work together and kind of figure out what's the best course of action for that patient, whether it's medications, diet, other therapies, that kind of stuff.
Got it. Okay, so shifting gears a little bit, let's talk about the immune system and the gut response. So how are the immune system and the gut intertwined?
Yeah, I think people don't actually realize that the majority of your immune system is actually within the lining of your gut. When we talk about the immune system, a lot of people just think about lymph nodes and that kind of stuff, but the lining of your intestines actually includes about 70 to 80% of your total immune system. And so the lining of the gut has a very difficult job, right? It's acting as the gatekeeper kind of within our body. It needs to allow the absorption of our nutrients and our fats that are important for day-to-day living, but it also at the same time has to block out these foreign invaders that can cause problems if they were to access our system. And so it actually uses the gut microbiome to help achieve this.
Got it. Okay, so that's an easy segue into the next question. What is the microbiome exactly?
Yeah, so the gut microbiome, I think a lot of people hear this and like, oh, the idea that we have about 100 trillion different organisms within our GI tract, and that's normal. They should be there. It's a combination of bacteria, viruses, and even some yeast. And really, in the ideal balanced state, the microbiome really helps us kind of support that intestinal lining and prevent those foreign invaders from crossing over. Now, when we get into an unbalanced state, more of the quote unquote bad microbiome and less of that good microbiome, that's when that kind of protective barrier starts to break down and you start to hear that term leakage, where people talk about the leaky gut. And where some of the bacterias and the metabolites from the bacterias can kind of cross that mucosal barrier. Once that happens, you start to see inflammation in those cells. And it's really that inflammation that can lead to certain diseases throughout the body. As medicine advances, we're starting to realize that it's not necessarily the fat in your diet that maybe leads to heart disease, but it's rather the inflammation being caused by very, very specific bacteria within our intestines that's leading to the plaques that develop within the heart and there in turn heart disease.
Interesting. Okay. So is everyone's microbiome the same then, or I'm assuming it's different, right?
Yeah, it's actually very different. There are large global variations. So in the general sense, the microbiome that you see here in the United States is very different than what you would see maybe in someone who's living in Italy or China. But there's also very regional differences. And so even though we might live in the same area of the country, the same state, our microbiome are not the same. And there's a variety of factors. Your microbiome is actually pretty firmly established within the first few years of life. And it's vulnerable to multiple different factors. So everything from how you were born, whether it was a vaginal delivery versus a C-section. A baby who's born vaginally actually is exposed to all of their mother's flora during the vaginal delivery. And a baby who's born via C-section, some studies have actually shown that their initial microbiome more matches the surgeon who delivered them than their mom.
Really?
Additionally, whether or not a baby receives their mother's breast milk or formula, I'm not here to say which is better, but it does impact the microbiome that that baby develops, and antibiotics exposure in life.
Okay.
Additionally, our diet has a huge role, and that's why there's the variations. Our diet is much different than the diet in Italy or China, and so our microbiome has adapted with our westernized diet and changed.
Interesting. Okay. So you sort of touched on this. So how exactly does the microbiome live in our bodies? Like, how does it thrive?
Yeah. So it's really a symbiotic relationship, as they say. We can't live without those bacteria. We need them. They're a very important source of certain vitamins and nutrients that we can't make on our own. And so that includes things like vitamin K, folate, thiamine, some B vitamins, and different amino acids like tryptophan. On the other hand, the bacteria can't really live without us. We are feeding our gut every time we eat. And we're not just feeding ourselves, we're feeding the bacteria and providing them the prebiotic fibers that they need to sustain within our system.
Got it. So what are maybe some signs that your gut might be negatively impacting your immune system?
Again, lots of very non-specific and vague symptoms. There's not one key thing that makes me think that in a patient versus a different patient. So again, nausea, bloating, abdominal pain, diarrhea, constipation. I'll also have patients come in with fatigue symptoms, chronic fatigue, or that brain fog that we hear a lot about nowadays as a complaint.
Would another symptom potentially be if someone seems to be getting sick frequently? Like, could that be an issue within their gut? Okay.
Mm-hmm. Yep. That increased inflammation, as we talked about, can increase your risk of lots of different diseases. Not necessarily your common cough and cold, but we see increased risk of things like celiac disease, inflammatory diseases, autoimmune diseases, heart disease, and even some cancers. There's also increased risk of things like Parkinson's disease and dementia.
Interesting. Okay. So what are some things that you can do to help support a healthy microbiome in your body?
Yeah. Again, without kind of, going to supplements and that kind of thing, natural dietary choices can really play a role in our gut microbiome. And so looking at those natural pre and probiotic foods. So things like root vegetables, carrots, parsnip, beets, turnips, yogurts that have active cultures in them. Some of those do get digested by your stomach bacteria, but your stomach acid, but other of those bacteria can be beneficial to you. And then fermented foods also have some natural pre and probiotics there. So things like sauerkraut, kombucha, kimchi, all those things can actually be very beneficial in the diet. Also making sure that you're getting adequate fiber in your diet on a day-to-day basis, because those fibers are needed by the gut bacteria. And so in general, a female patient needs anywhere between 20 to 25 grams of fiber a day, whereas a male needs anywhere from like 30 to 35 grams of fiber a day. And if you're having trouble, with some of those foods, they're not things that you enjoy, or you're having trouble just getting dietary fiber in, you can do a supplement of fiber and pre and probiotics. Both come in supplementation form as well.
Interesting. Okay, so obviously, you could do a prebiotic, a probiotic, and try and do a fiber supplement to potentially help things. I guess another question too is talking about probiotics, prebiotics. Can you give us some guidelines? Like what are good, maybe things to look for in choosing a probiotic, prebiotic?
Yeah, I get that question a lot because there's a lot of different things on the market. There's a whole aisle dedicated to it. It can be a lot to kind of go through on your own. And so there's really three main ingredients that you want to look for in probiotics. Okay. That is lactobacillus, bifidobacterium, and Saccharomyces. Saccharomyces is actually brewer's yeast. And so when we're talking about the lactobacillus and bifidobacterium, you want a probiotic that has about 10 billion colony-forming units, or CFUs, per dose. And for the Saccharomyces, or brewer's yeast, it's about 500 milligrams of that 3 times a day. If you're going to do a combo pill, which a lot of them come as, then you want to look for trillions of colony-forming units in each dose. The two probiotics that I most commonly recommend to my patients are Align and VSL number 3. Align is Bifidobacterium, whereas VSL number 3 is a combo of Lactobacillus and Bifidobacterium. Patients always ask which one to start first, and I'll tell you, it's a little bit of trial and error. There's not one perfect one for each patient. And so if you start with one and you take it for several weeks and you're not noticing a difference, then maybe try changing to a different one that contains a different strain of bacteria. So if you start with Lactobacillus, then try changing to Bifidobacterium for your next one. A question that we got as people were registering had to do about like testing the microbiome and why do we not test and direct treatments in that manner. And really there is no routine testing of the microbiome out there for the general population in the medical standpoint. And that's because we don't really know what the clear perfect microbiome is for each patient, and what might be healthy in one person's GI tract is not necessarily the healthy balance in someone else's GI tract for a variety of reasons, as we discussed. Additionally, we don't really know what to do with the information yet. Although, like I mentioned, we can recognize that certain bacterias are more prevalent in patients who have certain diseases, we don't have a clear link that bacteria is 100% the cause of that disease. And so I can only tell you what we know in medicine so far, but that this is a very big area of research in medicine right now. As far as selecting the different probiotics and why I like those two, in addition to the compounds that they contain, the research studies on patients in the general population for probiotics has mainly been symptom-based, because we've not, we're taking it to that next level nowadays with looking at disease-based research in probiotics and the microbiome. But traditionally, the research up to now has been, you take a host of patients who are otherwise healthy, have them record their symptoms, and then start taking a probiotic. And after a month on that probiotic, re-record their symptoms. And are they more likely to report that they feel better on X, Y, or Z probiotic? And Align and VSL number 3 tend to perform well on some of those studies. But again, that doesn't mean that it's the perfect probiotic for everyone out there. So you need to play around with it a little bit.
Got it. So why are some probiotics, like you go and you look at the grocery store, some of them are kept cold and some of them are shelf stable? Like, what's the difference, and does it matter, in the scheme of things?
Yeah. So for example, the two I mentioned, Align, you'll find on the shelf. Okay. VSL number 3 is stored cold. Okay. And it's really about how they're processed. And no, I don't think it makes a difference. Like I said, I recommend Align to a lot of my patients. But it really has to do with the manufacturing of it. So just because one is stored cold does not mean that it's more effective than one that's on the store shelf.
Okay, great. And I guess, we touched on this, but, when, would you encourage someone who's experiencing issues to also seek help?
Yeah, again, I think going early, kind of using this information to educate yourself and to try some things. But if you're giving something a trial and continuing to have symptoms despite the trial, or have any sort of question about, am I on the right track as far as my symptoms? And I think that's, again, something to really pay attention to, and that these disease processes, whether it's related to the immune system, the microbiome, or real true diseases, whether that's inflammatory bowel disease, irritable bowel disease, cancers of the colon, can have a real overlap in their symptoms. And so you want to be careful about self-treating too much. And if you're not feeling any better, really going soon to get an evaluation.
Do you ever recommend your patients to maybe keep sort of a diary, a symptom diary, like day to day, to kind of see if things are getting better or worse, or help provide some data for you?
A lot of times I tell my patients not to focus on the diary. And here's why. I think that the food diary can be very frustrating for patients, because the majority of the time what I hear from my patients are that they've tried the food diary before they've come to see me, just not necessarily writing it down, but maybe just paying attention to what they eat. And 99% of the time they'll tell me, I ate this food last week and I was fine. I ate this food this week and I feel bad. And so I think it just sometimes creates more frustration to look at it that way. Rather than, but I will work with them on diet, which I know we're going to talk about in a little bit, about just empirically eliminating things rather than trying to kind of source it out yourself through a journal.
Got it. Okay. So that is actually a great segue into the next section, which we're going to discuss diet fact versus fiction. So for a baseline for this part of our conversation, can you share what's the difference between a food allergy and an intolerance? And does it really matter? Like if you have an intolerance, you're still going to want to avoid that food anyways, right?
Yeah. This is a really good topic because I think it gets confused a lot, and people will say they're allergic to things that maybe they more just have an intolerance to, whether that's food, medications, kind of across the board. So the main difference really has to do with your immune system. So for example, say you're allergic to milk. We're going to talk about it. But so when the protein that's found in milk is detected by your immune cells, they start releasing a very specific antibody. And it's that antibody circulating throughout your system that generates the symptoms. And because this circulates throughout the entire body, you'll get not only GI symptoms like nausea, vomiting, diarrhea, but you might also get skin rashes and respiratory symptoms when you're exposed to that protein. In contrast, a food intolerance happens all within your GI tract. And it's due to our body's ability to break down and process that particular food or molecules within that food. And so those symptoms can overlap in that you'll have a lot of the GI symptoms like the nausea, vomiting, and diarrhea. But with a true intolerance, you're not going to get the skin rashes or the respiratory symptoms like you would in an allergy.
Got it. Okay, that's really helpful. Okay, so let's spend a little bit of time talking about gluten because gluten has seemed to become the enemy. You see gluten-free everywhere.
True.
Can you talk a little bit about what exactly is gluten and what types of food is gluten typically found in?
So gluten is actually a protein that's found in grains. And so things like wheat, barley, rye. A lot of times people think bread and pasta, but that's not the only places that you're going to find this grain. Beers, soy sauce, salad dressings, and it's a very commonly used as a thickening agent. So you're going to see it in a lot of sauces. And so, it's not just grain. It's not just bread and pasta. It's a lot of places in our diet.
So basically check your labels if you do have any sort of issues truly with gluten. So if someone is dealing with a gluten issue, what would their symptoms be? Whether it's, they actually have celiac disease or they may just have an intolerance.
Yeah. So celiac, again, it comes back to that immune system. So celiac disease is a very specific immune reaction that happens when the body is exposed to that protein found in gluten. Now, in non-celiac gluten sensitivity, as we call it, the immune system is not involved. Again, it's more about our digestion of gluten in the GI tract. For both, the symptoms do overlap again. And so diarrhea and bloating are the two most common symptoms of both of those diagnoses. In true celiac disease, though, you may also have other things like anemia, fatigue, poor growth, especially in children with celiac disease. And they also can get a very specific skin rash with celiac called dermatitis herpetiformis, a very itchy rash often found on the extremities.
Got it. How do you test for celiac disease to see if you maybe have an intolerance versus truly an allergy?
Yeah. So there's a blood test to look for celiac disease. And again, it's looking for that antibody in your bloodstream that the immune system is producing to gluten. If you do have an abnormal antibody test, then we often proceed to what's called an upper endoscopy, where we sedate you, put a scope down the esophagus into the stomach, into the first part of the small intestines. And this is where that reaction to gluten is occurring. And we'll do a biopsy of the small intestines to help confirm the diagnosis, looking for the physical changes of the intestines related to the inflammation there. Now, if a patient has already started a gluten-free diet or follows a gluten-free diet already, and they come and they want to figure out if they have celiac disease, that can be a little bit more challenging because one of the hallmarks here is that the antibody will normalize and the intestines will heal. And so in someone who has celiac disease, we can use the normalization of the antibody and the healing of the intestines as a marker of how well they're doing with their celiac or with their gluten-free diet. And so for those patients, in order to confirm a diagnosis, we may have to ask them to reinduce gluten into their diet. It's usually for several weeks. And then we can do testing to establish the diagnosis. There is a genetic test looking for the genetic markers that are known to be associated with celiac disease. However, this test is not perfect. So about 25% of the population carries at least a single marker, genetic marker for celiac disease, but only about 1% of the population actually manifests the disease. And so if you have a positive genetic test and are gluten-free, then we will often ask you to reintroduce gluten so that we can confirm the diagnosis.
Interesting. So if you are someone who, doesn't really seem to have any sort of reaction with gluten, is gluten really the enemy? Like, should you be trying to follow like a gluten-free diet? Are there any benefits to it, I guess?
Yeah, what I tell my patients is that the Westernized diet is very heavy in gluten. If you think back years ago, we were hunters and gatherers, right? We had nuts, berries, occasional meat. But as our diet has really shifted more towards like the farming culture, our exposure to gluten in our diet has significantly increased. Like I said, especially in the Westernized countries, the areas of the world right now that are experiencing the most rapid increase in celiac disease diagnosis are the Asian countries. And because their diet is becoming more Westernized over the recent years. Gluten itself is not necessarily an enemy. I think it's our overexposure to gluten in our diet. And that if you're eating foods that are very heavy in gluten, by nature, you're probably not having a very nutritious diet because we're talking about eating breads and pastas and these processed sauces. And so, because again, when you make your pasta sauce at home, it doesn't necessarily include gluten, but the pasta sauces over the counter are using gluten as a thickening agent. And so the more that we kind of use those processed foods, the more we're exposing ourselves to gluten. And so, oftentimes we're okay with small amounts of gluten in the diet. But as we increase that exposure, we tend to see more symptoms in our patients. And so I'll just have them pay attention to their gluten and try to cut back on gluten rather than completely eliminating gluten.
Okay, that makes a lot of sense. That does make a lot of sense. Could you briefly touch on the difference between maybe celiacs and someone who has a wheat allergy?
Yeah. And so, again, goes back to the immune system here. And so with celiac disease, that antibody that we're looking for is what's called an IgA antibody in the bloodstream. The immune system actually makes several different antibodies, these immunoglobulins, and they're IgM, IgA, IgG, and IgE. Now, again, for celiac, it's an IgA-mediated reaction. In a wheat allergy, we're talking about an IgE-mediated reaction. Much more common with the IgE to see the hives and the respiratory distress. Whereas celiac disease, you're not going to see those because of the IgA-mediated reaction. And so, true wheat allergy is pretty rare, but working with an allergist to make that diagnosis and that distinction is important.
Got it. Okay, shifting gears a little bit, let's talk about dairy, because dairy is also getting a little bit of a bad rap these days. Can you share what is lactose intolerance and what are those symptoms that someone would have? So lactose intolerance really relates back to our body's ability to create enough enzyme. The enzyme is called lactase, and that's what's needed to break down milk in our diet. It's very rare to be born with complete lactase deficiency. Actually, babies are pretty good at producing lactase and digesting milk in their diet. But the production of lactase actually normally decreases with age. You will also see a decrease in that lactase production following like an episode of gastroenteritis. The reason for that is the cells that produce lactase are right at the surface of the lining of the intestines. And those cells are often shed
after an episode of gastroenteritis. And so until you kind of can regenerate that and heal, you may have a short-term lactase deficiency. And so what happens is, in the setting of these deficient lactase enzyme, is that the milk sugars are not broken down and end up actually getting fermented by the bacteria in our intestines. It's that fermentation process that creates the symptoms, because if anyone's ever fermented anything, you know there's air production during the fermentation. And so you get a lot of bloating, gas, cramping, and watery diarrhea after ingesting that.
So if you have patients that may have been experiencing some of the issues like we talked about earlier, issue with the mind-gut connection, or maybe some issues with their microbiome, do you see them potentially having like these bouts of like dairy intolerance because of, what's going on with their systems?
Yeah, I oftentimes will talk to them about eliminating dairy at those times. When we talk about diet and the empiric elimination, I oftentimes have them do a trial of eliminating dairy from their diet to see how they respond. Additionally, we have testing for lactose intolerance. It's done by a breath test, which we can do in our office if there's a question of whether or not the lactase is a problem. But oftentimes just a dietary trial and an elimination can answer that question easily without having to go through the formal breath test.
Got it. And then, so is there like a further step, I'm assuming yes, to like a milk allergy versus just having a lactose intolerance, right?
True, yeah. The true milk allergy is actually, again, pretty rare in adults. We'll see it sometimes in children. When they're exposed to milk products, either through mom's breast milk or once they're introduced onto dairy in their diet, then they'll get some diarrhea. They may even have rectal bleeding, which can be a real sign. And if a baby presents with blood in their diaper, a sign that they're having an issue with dairy. And then oftentimes they'll also develop skin rashes because, again, it's more of an allergic reaction. Usually babies actually outgrow this allergy, interestingly. And by age 5, they're usually able to tolerate dairy products again. Again, different than the intolerance. This is a true allergic reaction.
Got it. Okay. So talking a little bit more about some different types of diets, can you explain what exactly is the FODMAP diet, and when would someone consider, using that diet?
So yeah, I like the FODMAP diet. I use the FODMAP diet a lot. It is a diet that was researched at Stanford, and FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which are sugar alcohols. These are all carbohydrates that are found in food. And the reason patients have symptoms after eating these foods is because of that fermentation process. So these foods are very easily fermented by the gut. And that leads to excess gas production and accumulation within the intestines. And for a lot of patients, they'll have kind of a hypersensitivity to this distension from the gas, creating cramping. And the fermentation process also draws excess water into the intestines, resulting in diarrhea. Now, again, they are not inflaming the intestines. This is again about how the foods are getting digested within our intestines and thereby leading to symptoms. It includes a lot of very nutritious foods. And so people will come to me and say, I shop only at Whole Foods. I have a good diet. And I have to kind of break it down for them that it's not necessarily the quality of the food that you're eating, or that you're only eating, fruits and vegetables, that you're following a vegan diet or something like that. You can be following a very healthy diet and still be having symptoms related to the digestion of your food. And so, for example, things that are on the bad list include avocados, watermelon, and so some really good foods. It also includes gluten on that list, and dairy, as I talked about. It was originally kind of designed to be done as an extended, 6 to 8 weeks of complete elimination of all of these, what we call FODMAP foods, and then a slow reintroduction phase where you reintroduce one food at a time while monitoring your symptoms to see if you can really pinpoint what are the specific triggers for your gut, because it's a little bit different between patients. Mm-hmm. What I will say is that I see some common overlapping in what my patients are able to tolerate and not tolerate. The most common things that patients, when they come back to me after trying a diet like this, that they have kind of pinpointed as trigger foods tend to be onions and garlic.
Really?
Which is, yeah, and it's kind of frustrating because they taste good.
Yeah.
Everything. Some of the patients are able to tolerate these in small quantities. Like if they're making a recipe, they use a single slice of onion as opposed to the whole onion, or they're able to tolerate the onion powders and kind of the dried ingredients as opposed to the raw. But, those are the two most common. And so, it's a challenging diet. It needs to be done oftentimes with the help of a dietitian if you're going to do it truly 6 to 8 weeks of true elimination, because it's difficult to follow. And we also want to make sure that while you're restricting all of these foods, that you're continuing to get all the nutrients that you need on a day-to-day basis. There are apps on your phone that can help. It can be really effective if you can stick with it, but it's definitely not easy to adopt a diet like this for those 6 to 8 weeks.
Got it. From a digestive health perspective, do you see red flags with certain diets that are super trendy right now, like the keto diet, for example?
Yes. In general, when I talk to my patients about their diet, I'm leery to adopt any of the fad diets and anything that requires kind of a lifelong change, right? So the nice thing about the FODMAP is it really is designed to be 6 to 8 weeks with a reincorporation of foods to get you back to more of a natural diet. These fad diets, as we see, can sometimes be difficult to follow, especially long-term. And things like the keto diet and the Atkins diet, when it was around, are very high in saturated fats, which are not necessarily a healthy diet in themselves. And I also see a lot of GI symptoms. In the patients who follow the keto diet, I oftentimes have patients come to me with constipation when they adopt that diet because of their fiber intake and their dairy intake and what that does to the GI tract. And so I think the best diet is one that you can be maintained on long term rather than short term. And so these fad diets just really, I would be cautious with.
Got it. What do you think about some of these home sensitivity food tests? Like I'm seeing a bunch of stuff advertised on social media. Do you think they can provide valuable information, or are they just a waste of money?
Yeah, I see them a lot too. So the testing itself comes back to that question of, is it an allergy or sensitivity? Again, very often confused. And so traditional allergy testing that you would get with an allergist, the skin prick, the blood test, they're looking for what that IgE, as I mentioned, but not just the presence of the IgE, but the corresponding symptoms when exposed to that food. And so, a blood test that shows an elevated IgE, but a skin prick without a hive might mean that you're not actually truly allergic to that food. And so both of those things have to be done together. The at-home tests that you see are looking for IgG levels within the body. The problem is that we don't have a lot of science behind this yet. There's no clear indication that an elevated IgG marker necessarily means anything bad. It might actually mean that you're more heavily exposed to that food and your body has adopted this IgE as a way to, from chronic exposure to it. It may actually mean that your body does a good job digesting this food rather than having difficulty digesting this food. And so oftentimes you're left with the results that make you want to eliminate foods that might not necessarily be the source of problem for you. Additionally, these are completely out of pocket. They are not covered by your insurance company. The Everlywell test, which is probably the most commonly known, comes up on my social media. I think I actually graduated with the girl who helps advertise for that one. It costs about $160 out of pocket. So it's not a huge expense, but it might be a waste of $160, to be quite frank. These companies are banking on the fact that patients are very frustrated when they're having GI symptoms and have felt that they've not been able to establish a diagnosis. And so they're kind of desperate for anything that can give them any leeway into what they can do to feel better. And the companies are really banking on that, and they're capitalizing on it by making money on those patients who are looking for answers. But it just might not be providing us the right answers that we need.
Too bad. So something that could be really convenient, but not necessarily provide you data-based results. So,
yeah.
Okay. So let's talk a little bit about optimizing our health too. Could you spend a few minutes talking about colon cancer and maybe give us a refresher for, what are some of the baseline guideline recommendations?
Yeah. So the guidelines actually changed within the last few years. We used to start screening colonoscopies at age 50. Mm-hmm. The guidelines have now gone backwards, and we start at age 45 now. We've been seeing an increased risk of colon cancers in younger patients, probably for a variety of factors, including our diet and our microbiome. But for that reason, the GI societies have recommended that you start your screening colonoscopy at age 45. As far as intervals after that initial colonoscopy, it really depends on the findings at that time, in addition to your family history. And we continue colonoscopies at least up through age 75. After 75, it's kind of a case-by-case basis up until the early 80s, depending on the patient. I have a lot of patients who are in their 80s, young 80s, and are very healthy. They're cruising, they're golfing. And so it makes sense to continue screening them for colon cancer even into their 80s. I have some patients who in their 70s even are quite sick and have other comorbid medical conditions, are not in the best state of health, and it makes sense to stop screening for colon cancer younger in that particular patient. But yep, starting at age 45. So probably a lot of us are close, if not there. And so make your appointment.
Got it. Are there some specific symptoms that people, if they're not yet 45, that they should not ignore and maybe go see someone to potentially have a colonoscopy sooner?
Yeah, I say never ignore bleeding. And a lot of people do. They brush it off thinking it's just a hemorrhoid. And I tell you that, 90% of the time it is a hemorrhoid, but none of us have X-ray vision. And so we don't know for sure that it is your hemorrhoid and not potentially something else that is causing the bleeding. I've had even very young patients in their 20s come in where their primary doctor have told them the blood was just from a hemorrhoid. And lo and behold, they had something like colitis or a very large colon polyp that was getting traumatized because of its size. And so it was causing bleeding. And so had we not caught that early, that patient was very likely going to be one of those young colon cancer diagnoses. And fortunately, we had the opportunity to intervene early and affect her long-term outcome. So if you see any blood, don't just brush it off as a hemorrhoid. Make sure you get checked.
That's great advice. For those of us who may not have had a colonoscopy yet, can you briefly explain what the procedure is like?
Yeah. So essentially, we use kind of a flexible tube that's got a light and camera on the end to examine the entire colon, kind of starting at the rectum and advancing all the way through over to the right side of the colon where the appendix is. In order to do this, the patient has to do a colon cleanse the day prior to the procedure. So they drink a laxative. I personally use Miralax, which is an over-the-counter powder mixed with Gatorade just to help with hydration. And they drink that the evening before the procedure. It flushes everything out of the colon. And then they come here to my office. It's an outpatient procedure. It is sedated. And so that's something oftentimes patients are very concerned about. They don't want to be awake. It sounds awful to them to have a procedure like this awake. So although we can do it awake, 99% of the time, my patients opt for the sedation. And so here we do a deep sedation. They're completely asleep. They do not feel or see anything during the procedure. And it takes about 20 minutes for us to examine the colon, looking for colon polyps. Those are those precursors to colon cancer. And so although not every colon polyp will become a colon cancer, we don't know for sure which one will and which one won't. Mm-hmm. And so we take them all out. Mm-hmm. I oftentimes talk to my patients about, it's like your freckles or your moles, right? You can watch that mole on your arm and remove it only if it changes. But for the colon, we don't have that same opportunity. And so we just have to remove all of them.
Got it. Do you have any specific additional advice for people that may have a family history of colon cancer?
Yeah. In general, colonoscopies start sooner if you have a family history of colon cancer.
Okay.
And so generally they'll start at age 40 if you have an immediate family member with colon cancer. And by immediate, I mean mom, dad, brother, sister with colon cancer. Then you start your colonoscopies at age 40 or 10 years younger than your youngest family member. So if your sister had colon cancer at 48, you start at 38. And then you often will get more frequent colonoscopies. And so every 5 years instead of every 7 to 10 years, based off of your family history. Like I said, the first degree family members are the most important, mom, dad, brother, sister. But if you start to have multiple, what we call second degree family members with colon cancer, think about your cousins, aunts, uncles, grandparents. Then if you have more than one second degree relative, then we also will treat you as a high risk for colon cancer screening.
Got it. And I guess, are there other cancer screening things that like are important to you from a gastrointestinal perspective?
Yeah. The other one that we talk about is, as far as screening, is pancreatic cancer.
Okay.
That's a really scary hot topic for patients because oftentimes it's caught late and the treatment options are limited. But if you have a family history of pancreatic cancer, then you may qualify for screening for pancreatic cancer. So you have to talk with your doctor or your gastroenterologist. Additionally, there are certain genetic markers that increase your risk of pancreatic cancer. And so things that you might not even think about. So the BRCA genes, in addition to being associated with breast cancer, they have an increased risk of pancreatic cancer. And so that's why it's so important to talk with your doctor about your family history and whether or not you have any risk factors.
That's great information. I had no idea that you could look preventatively potentially for pancreatic cancer. Thank you for sharing that. Two other common items that you mentioned that come up with your patients are the SIBO test and then also EPI. Could you explain a little bit about what the SIBO test is and when someone might do that?
Yeah, so the SIBO breath test, so predominantly the bacteria that we've talked about up until now is within the colon. SIBO stands for small intestinal bacterial overgrowth. And so the intestines is really good at kind of sweeping all that bacteria down to the colon. As the food moves, the bacteria moves to sweeping it all down to the colon. But when there have been previous maybe surgical procedures that alter our anatomy or certain medical conditions that alter the contractions of the intestines, things like diabetes, gastroparesis, or in autoimmune diseases like scleroderma, the bacteria within the small intestines might kind of become stagnant and start to overgrow. That's what leads to our symptoms in these patients. The predominant symptoms are abdominal pain and bloating, followed by diarrhea. In real severe cases, they might end up with malabsorption sort of symptoms with weight loss and some vitamin deficiencies. So we can test for that in our office with a breath test. Okay. The patient drinks a small amount of liquid that has a carbohydrate in it, and then we have them breathe into a machine every 10 minutes for about 2 hours. And that machine is looking for production of methane and hydrogen gas within the small intestines by the fermentation of that carbohydrate for small intestinal bacteria. It's normal to see that fermentation in the colon, and that's why we stop the test after about 2 hours, because most of the substrate is starting to enter the colon by that point. And so if we see the spike then, that's more normal. But an early spike of those methane or hydrogen gases might indicate small intestinal bacterial overgrowth, which we can treat with an antibiotic.
Got it. Okay. And then can you explain what exactly is EPI and why does that come up frequently with your patients?
Yeah, so that stands for exocrine pancreatic insufficiency. It's actually fairly rare, but there are commercials about it nowadays. You'll hear about it on the radio. And so, and that's why I have to talk with patients about it a lot, because they've read about it or heard about it on the radio. And so the pancreas secretes certain digestive enzymes that help break down particularly fats in our foods. And so we can test for the amount of pancreas enzyme that a patient is producing by collecting a stool sample. And we look for a pancreatic elastase enzyme in that stool sample. a patient might be producing low amounts of enzyme if they have certain medical conditions that can affect the pancreas. This includes everything from celiac disease to recurrent pancreatitis, either from autoimmune diseases or from alcohol use, or to some congenital or structural abnormalities of the pancreas that they might be born with. If they do have a low level of pancreatic enzyme, we can actually replace their pancreatic enzyme with supplementation. They have to take it with each meal to help digest the fats in their foods.
So are these advertisements that are on the radio, are they typically coming from like the people that make those medications? Is that why it's sort of like out there, do you think, even though it's rare for most of your patients?
You got it. We are definitely being manipulated in multiple ways on a day-to-day basis by, different companies out there. And I don't want to give these pharmaceutical companies or these drug companies a bad rap, but we're manipulated on a day-to-day basis from everything from the color of the sign that McDonald's uses to the commercials you hear on the radio.
Yeah. Okay, let's see if we can take a few questions. We have a few minutes left, and some people have been submitting things on the side. So let me see here. I think this is a good one for you, Dr. Harris. Acid reflux. It seems like there's an increase in people using medications like Nexium for acid reflux. Is there an increase in Americans in general having acid reflux? And is there any harm in taking a supplement or medication like Nexium?
In general, yes. I think we see increased acid reflux in our patients for a variety of reasons. One of the most common reasons that patients will experience increased reflux, and one of the ways we can actually treat it, is by looking at a patient's weight. And I'd say that in general, American tend to carry a heavier BMI. That increased pressure within the abdomen increases the pressure on the stomach. And the esophagus is kind of like our pop-off valve. It helps relieve that pressure by allowing the contents to kind of reflux up into the esophagus. Now, gastric contents are acidic and can damage the esophagus, resulting in, what we call esophagitis. And so, yes, that is one of the reasons we're seeing increase in it. What I also say is that because a lot of these medications have been moved to over-the-counter sales, a lot of people are maybe inappropriately using these medications and labeling themselves as acid reflux without having appropriate testing for acid reflux. And a lot of times they just start taking it, they feel better on it, and they never stop. Really, there are risks to the medication. And so although those risks are small, you really only want to use the medication if you have a confirmed diagnosis and you're working with a physician to control the dose and the duration of treatment.
And there are certainly types of foods and drinks that can contribute to someone experiencing those types of symptoms. Would you share like a couple of those foods or drinks that can spike acid?
Yeah, so the general acidic foods, we're thinking of like tomatoes, spicy foods, citrus, caffeinated beverages, alcohol, peppermint, chocolate. So it's a lot more than you just think. It's not just spicy food. And so, you can find diets online or work with your doctor on kind of our anti-reflux diet and lifestyle management. And if you fail the diet and lifestyle management, that's when you might need to incorporate a medication like Nexium.
That makes sense. Okay, I think we have time for one more question. And I don't know if you're going to have enough time to answer this appropriately, but we did receive a question that asked about what's the difference between IBS and IBD? And do the nerves play a part in both or either of those conditions?
Yeah, so in inflammatory bowel disease, which is the IBD, there is very distinct physical changes to the intestines. It's usually being driven by the immune system, inappropriately attacking the intestinal lining and recognizing it as a foreign invader. As opposed to IBS, or irritable bowel syndrome, where the intestinal lining is perfectly healthy, there's no inflammation, there's no damage to it. But your symptoms are being driven again by multiple factors, including your microbiome, your diet, and those sort of things. So really, it comes down to the physical damage of the intestines that happens with inflammatory bowel disease and kind of the normal, healthy appearing intestine in irritable bowel disease.
And so I assume there's diagnostic testing that you can do, right, to like see whether or not there is damage to that lining.
Correct. You would need to work with a gastroenterologist. It almost always requires a colonoscopy and sometimes an upper endoscopy to make that diagnosis.
Got it. Got it. Well, we are just now at the 1 hour mark. So I want to be respectful of Dr. Harris's time. Thank you so much for joining us. I know that I have learned so much information by spending this hour with you. I really appreciate you answering our questions and spending time with the Miami alumni. So thank you very much, Dr. Harris, and thank you to those who tuned in today. I hope you enjoyed our session. Please stay tuned for upcoming events that are coming down the pike for the Miami Women's Network. Until next time, thank you, everybody.
Bye. Thank you.